Good afternoon, good morning, good evening from around the world. My name is Salih Hendricks and I'll be moderating the Bridging the Gap for multidisciplinary care for renal Welcome from the IDF. This webinar will be recorded. We can activate Zoom. Generate the recording slides will be feedback questionnaires will be sent to all registrations on few days. Participants who attend at least 80% of the event live will receive an attendance certificate only if they complete the feedback questionnaire. Please check your spam folders if you have not received them by the 23rd of August. Please use the Q&A function to post your questions to the speakers and participants. We're going to have a welcoming from the Atlas, Professor Carol Pollock via video.
There is no doubt that the rising rates of chronic kidney disease is driven in large part to an increase in the incidence and prevalence of diabetes, particularly type 2 diabetes. Factors that coexist with diabetes and chronic kidney disease, for example, hypertension, obesity and dyslipidemia, contribute to the vast excess that we see in morbidity and mortality in this population, primarily due to cardiovascular disease. The incidence of diabetes has doubled in the last 3 decades from 7% to 14%. And the most rapid increases that we've seen are in the low middle income countries. The global prevalence of diabetes is more than 20% in people over the age of 65 years. And of course, 50% of people are unaware that they have diabetes. So this means more than 50% of people are not treated appropriately. Regional disparities exist, particularly in areas such as the Middle East, Africa and Oceania, and in some areas they peak at over 40% of the population, particularly in the older demographics. And of course, treatment in these areas is often limited and inequities exist. If we look at chronic kidney disease, the underlying cause of end-stage kidney disease requiring renal replacement therapy varies between something in the order of 35 to 60%, depending on the demography. But it is important to note that at least one person dies every 20 seconds worldwide from chronic kidney disease. We also recognise 14% of the population internationally now also have signs or clinical indications of chronic kidney disease, which means approximately 850 million people are affected by chronic kidney disease. Now, we know that there have been several clinical trials thankfully, in the last 7 years that have demonstrated benefit from pharmacological intervention in people with chronic kidney disease, and particularly with the combination of kidney disease and diabetes. But we recognise that the uptake of these medicines, which will vastly improve outcomes, has been patchy. So really the only way that we are going to look at how the uptake occurs is through real-world studies. And in this regard, iCaReMe is a real-world study that enrolled patients across 25 different countries from 6 WHO regions investigating diabetes, chronic kidney disease, and various comorbidities and their appropriateness of treatment. So this information is critical for policymakers and governments because the WHO has now designated chronic kidney disease as a non-communicable disease of significance, which means that there is a need for governments and agencies to deal with chronic disease or chronic kidney disease in an equitable fashion and promote appropriate screening, treatment, and importantly, primary prevention. So I commend this session to you as it is so important for global health.
Okay, we thank our chair. Okay, our next speaker will be Dr. Bianca Hemmingsen, and she will present her presentation.
Thank you. Thanks a lot, Salih, and thanks a lot to IDF for convening this meeting. My name is Bianca Hemmingsen. I have the technical lead for the diabetes program at World Health Organization headquarters. And most recently, as just mentioned in the video, we have also started to integrate kidney disease into our program more effectively. As we all know, diabetes is one of the leading causes of chronic kidney disease. This is not a rare complication. It affects about 40% of all people living with diabetes. Diabetes, kidney disease, and cardiovascular disease, they're deeply interconnected. And when the kidney function declines in a person living with diabetes, the risk of cardiovascular disease and early mortality increases. And already now we both have diabetes and kidney disease among the top 10 leading causes of death globally. In order to address this increasing prevalence of diabetes, which is one of the main drivers for the increase as well in chronic kidney disease, the World Health Organization launched the Global Diabetes Compact in April 2021. This was very timely because just 1 month after member state, they committed to give higher priority to diabetes within the national strategies and universal health coverage packages. There was quite a lot of momentum back then, and 1 year later in 2022, member states also supported the global diabetes coverage target, which is quite ambitious. There are like 5 targets saying 80% of people with diabetes should be diagnosed, 80% should have good control of glycemia, 80% should have good control of blood pressure, 60% of people over 40 years, they should receive statin. And finally, 100% of people with type 1 diabetes should have access to affordable insulin and self-monitoring by 2030. But most recently, there have also been a movement or an increased tension around kidney disease. And we saw last year in May 2025 that member states also committed to prioritizing kidney disease. The document outlining this commitment it explicitly recognizes diabetes, but also hypertension as shared risk drivers and call on countries to integrate kidney disease care into their national strategies and primary health care. So in order to help member states to achieve these commitments. The World Health Organization collaborates with member states, but also support them in providing technical guidance to help them integrate diabetes and kidney disease, both prevention and care. So how we do it is to provide practical tools and products that facilitate the integrated care, but also increase awareness and also training of healthcare workers. In addition, of course, access to medicine and associated health technologies is a must, because otherwise we cannot diagnose and treat. And this is also an area where we work on to strengthen, so people, they can be tested, monitored, and treated for both kidney disease and diabetes. So what we need now is that the countries, they need to translate these commitments on kidney disease and diabetes into national action, into their universal health coverage packages as well. So primary healthcare system, they need simple, low-cost detection tools. They already exist. We have eGFR and urine albumin testing, and this needs to be built into routine diabetes care. All of us on this call, I think we just need to keep driving the progress so the political commitments, they can translate into predictable financing and equitable access for everyone with diabetes and kidney disease. So we have the data, the knowledge, and the political commitment. So I think the task ahead, it's the implementation where we all can play a role. So thanks a lot, Salih. That was all from my side.
Okay, thank you, Dr. Bianca. Our next speaker is Professor Masaomi, and he will present his presentation to us now. Thanks. The floor is yours.
Thank you. Greetings from the ISM. I'd like to thank you for the kind invitation. Diabetic kidney disease, or DKD, remains the leading cause of CKD and kidney failure worldwide. Despite remarkable progress in diabetes care over the past several decades, many patients continue to develop progressive kidney dysfunction and cardiovascular complications. Fortunately, the therapeutic landscape has changed dramatically in recent years. Next slide, please. This is just disclosure of my COI. Cardiovascular kidney metabolic syndrome, CKM syndrome, is a health framework that connects obesity, diabetes, kidney disease, and heart disease. Instead of treating these problems separately, we use this concept to treat the whole body. This prevents the organs from damaging each other. Next slide, please. For more than 2 decades, inhibition of the RAS has been the cornerstone of therapy. However, perhaps the greatest advance in the past decade has been the introduction of SGLT2 inhibitors. Large clinical trials have consistently shown that SGLT2 inhibitors slow the decline in kidney function, reduce progression to kidney failure, and decrease hospitalization for heart failure. Importantly, these benefits are observed even in patients across a broad range of eGFR. Furthermore, SGLT2 inhibitors slow progression of non-diabetic kidney disease and are now the gold standard for treatment of both diabetic and non-diabetic kidney disease. Next slide, please. More recently, non-steroidal mineral corticoid receptor antagonists, MRAs, have emerged as another important therapeutic option. Finerenone has demonstrated significant reductions in kidney disease progression and cardiovascular events in patients with DKD. Although monitoring for hyperkalemia remains necessary, this therapy provides an additional layer of kidney protection through anti-inflammatory and anti-fibrotic mechanisms. Aldosterone synthase inhibitors ASEs are a novel class of drugs that are highly selective for aldosterone synthase with little inhibition of 11-beta hydroxylase. Although ASEs are emerging newer drugs still in clinical trials, theoretically, ASEs act upstream by turning off the production of aldosterone to block both genomic and non-genomic effects of aldosterone with less side effects, such as gynecomastia. Next slide, please. Another major development has been the increasing use of GLP-1 receptor agonists. Recent evidence suggests beneficial effects of GLP-1 receptor agonists on kidney outcomes. Of course, traditional management strategies targeting blood pressure, blood sugar, lipid, and lifestyles are foundational approaches of DKD treatment, each of them still holding importance in current paradigms. However, the four pillars, RAS inhibitors, SGLT2 inhibitors, non-steroidal MRAs, and GLP-1 receptor agonists, are now enhancing DKD treatment. Next slide, please. These advances have transformed DKD from an inevitably progressive disorder into one in which meaningful preservation of kidney function and reduction of cardiovascular events are achievable. Last but not least, I would like to emphasize that DKD is a systemic disorder, as we have to treat patients with CKM syndrome, multidisciplinary care involving diabetologists, cardiologists, nephrologists, primary care physicians, dietitians, pharmacists, and nurses is essential. Thank you very much for your attention. This is the end of my talk.
Okay. Thank you for your presentation, Professor Matsumi. Okay, thank you. Our next presenter will be Professor Jeya, and he will actually deliver his presentation to us right now. Thank you.
Thank you very much, Salih, and hi, everyone. Thank you to IDF for giving me the opportunity to present. Not so much of it's not a very scientific part of the presentation, but I think a little bit more about the practical, how we could actually integrate a practical model in how we could actually deliver care in patients with diabetes living with cardiorenal complications. Next. So next. So I'm an endocrinologist in a tertiary care hospital from Malaysia. And in Malaysia, just to give you a perspective, the burden of diabetes is heavy. 1 in 6 of adults in Malaysia actually are living with diabetes. And if you look at a survey done in a tertiary care hospital, including our hospital and other tertiary care hospitals in the Klang Valley, close to Kuala Lumpur, almost a third of our patients actually have cardiovascular disease, and a third of them also have CKD, chronic kidney disease at stage 3 or worse. Next. So if you look into the delivery models, how we actually deliver care to people living with diabetes and these conditions, right now we are really not doing that great. I think this condition is applicable in Malaysia, and I think also to probably in many other regions or countries around the world as well. Because in many specialist care, the care is actually very fragmented. If you see a nephrologist, the kidney becomes priority. If you see a cardiologist, the heart becomes priority, and an endocrinologist, it might be the glucose alone. So we could all, although we are physicians who, should be able to manage everything as a whole, but we tend to become fragmented or work in silos because of our specialization. There is also data from the Target Type 2D study, and that was actually a study that was done again in the Klang Valley in Malaysia to show that, despite having, as Prof Nangaku had mentioned just now, the impact of SGLT2 inhibitors, GLP-1 receptor agonists, and even non-steroidal MRAs, the use of these GDMTs here, I'm referring to guideline-directed medical therapies, the uptake is still low. And it does not give a great patient experience. So if you have a patient A who is actually moving from one specialist clinic to another specialist clinic, that's actually not very good from the patient experience point, because he or she actually needs to go to many different stops to actually manage his comorbid cardiorenal conditions. And also, obviously, this will lead to high resource utilization. It's not really the best of delivery care models. Next. So hence in Malaysia, we had adopted the CareMe. I mean, this is part of the global CareMe alliance. And in Kuala Lumpur, the hospital where I work at, I've had the privilege to actually lead the CareMe approach, or the CareMe clinic, multidisciplinary clinic, in which the aims are actually to enhance the GDMT use, to improve the patient experience, really putting the patient in the center of care, and enhancing the use of resource. And so when we brought this up to the hospital management, they really took it up immediately and thought that, this will be something. And because we had a lot of limitation in terms of space, this is actually a virtual integrated CareMe clinic. CareMe as in cardio, renal, metabolic virtual clinic. Next. So basically the CareMe model in Malaysia, some of the key points is that it's patient-centered. We are trying to integrate the cardiorenal and metabolic conditions. And of course, we also want to incorporate some of the allied health whenever it's necessary, the dietitian, the diabetes nurse educators, the sports physicians, cardiac rehab, and even dialysis nurses to promote the use of GDMT. And obviously, it has to be personalized and optimized. And of course, we are also part of the global registry and global alliance. And we try to make it as individualized, or rather, something that's adapted to our local setting for sustainability. Next. So if you look at the workflow in which the CareMe clinics, how we're actually trying to deliver clinics here in University Malaya Medical Center, where I work at, is because of restraints or constraints with regards to space, physical space, manpower. We have learned from the COVID-19 pandemic that many things can be done virtually on Zoom. And that's exactly, just like how this meeting is happening, that's exactly how we are having our own CareMe MDT, so multidisciplinary team meeting. So the patients actually are not required to attend. It's doctors or physicians from different units or different specialties, together with some of the allied health supporting staff, the diabetes educators, they are key, dietitians, physicians, sometimes sports physicians, and other kind of allied health who can actually help us manage the patients well. And the patients are actually discussed, and really the leader in this whole team is actually my CareMe nurse navigators. They are our nurses who are really passionate, who actually form the bridge communication between us physicians or the healthcare provider team and with the patients. So in these meetings that happen every week now, we discuss close to about 15 patients, and the issues are highlighted in terms of metabolic conditions, renal conditions, and cardiac conditions. And again, the medications are reviewed and assessed. So GDMT, again, I stress, I think maybe some of you may have missed it. The short form that I'm using here is actually guideline-directed medical therapy. So there are certain pillars or guideline-directed therapies if you have diabetes. There are certain guideline-directed therapies if you have heart failure. There are certain guideline-directed therapies if you have kidney disease. And this is what we are trying to review and make sure the uptake, patients actually have these drugs, these important medications, and other issues are also discussed, because it could be things like hypoglycemia. It could be diet related. It could be lifestyle. It could be personal. And that's where we actually get the perspective of all the different healthcare member teams. The changes are made and documented in our electronic health records, and patients are contacted. So if changes need to be done, patients are actually communicated via our nurse navigators, who are really our leaders who navigate this CareMe model in Malaysia. So the patients then do not need to go to multiple clinics. They only need to be seen in one of these clinics. So if the patient actually has a renal appointment, a cardiology appointment, and an endocrinology appointment, we discuss in that multidisciplinary meeting that we have online to decide what is the predominant problem, and the patient actually is saved from multiple visits to our hospital. Because we are actually in a major hub in Kuala Lumpur where parking is difficult, traffic is horrible. Many of our patients travel long distance in traffic to actually come to our hospital. So we actually felt and it does translate to improved use of resources and actually improves the patient experience. And we're actually doing this in a study format. So it's actually being compared with standard of care arm, and data and publications are in works, and hopefully we'll be able to publish soon in the next couple of months some of our outcomes. So I think again, somebody was asking about GDMT, say guideline-directed medical therapy. So next. So so this is actually just the team, and initially it started with about 4 or 5 members, and it's expanded over the time. We have actually now run for close to about 1.5 years. We hope to actually expand further, and we really are looking forward to some of the data and publications. We are also collecting quality of life measures of patient satisfaction related data so that can be reported, and it's very much important for us so that we can bring this forward to our own hospital administrators, and hopefully, we can actually in Malaysia expand this further to other hospitals, other states, and also in the region. So with that, I thank you, and back to you, Salih.
Okay, thank you very much, Professor Jeya. We really appreciate that. Next lineup is our lived experience person, and Ms. Anita Sabidi, and you can go ahead to present yours. Thank you.
Thank you so much, Salih. Okay, hi everyone. Good morning, good afternoon, good evening. My name is Anita Sabidi, and I'm an IDF boost girl voice from Indonesia, and I've been living with type 1 diabetes for nearly 3 decades. Next, please. This is my journey. So like many people living with diabetes, my journey has not been defined by diabetes alone. During my second pregnancy, I developed severe preeclampsia, which eventually led to chronic kidney disease and cardiomyopathy. At first, I thought kidney disease was just another laboratory result on a piece of paper, but over time, I realized that kidney disease affects much more than numbers. As a person with diabetes living for nearly 3 decades, I often more focusing on carbs intake, and I eat whatever protein that I want. But when I was diagnosed with kidney disease, I need to limit my protein intake. I need to know the minerals coming from the vegetables that I will consume. And it really stressed me out. Why? Because it's a new diagnosis after I just gave birth to my second baby, and it made me question a lot of things. It affects on how I plan my day, my family, my emotions, and also about my hopes for the future. At first, fortunately, because of my condition, was detected early and managed through continuous follow-up. So I'm able to slow the progression and preserve my kidney function. So that experience changed my perspective completely. Today, I'm not only speaking as a person living with diabetes and chronic kidney disease, but also as a patient advocate who believes that early detection and timely intervention can truly change lives. So this new diagnosis as a person with chronic kidney disease reminds me of one important lesson. This was not the end of my story. It became the beginning of my advocacy. Next, please. Why multidisciplinary care matters. So one of the biggest lessons I learned is that kidney health cannot be managed by one healthcare professional alone. Throughout my journey, I have been supported by an incredible multidisciplinary team. So in my hospital, I have my multidisciplinary team. I have an endocrinologist, cardiologist, nephrologist. I also have celiac and rheumatoid arthritis. So I also have my gastro specialist and my autoimmune specialist, and also have thalassemia. So I have also my hematologist. So it's a complex multidisciplinary team, but they work together. Why? Because we know that, for example, since I limit my protein intake, red meat intake, which means I will be into a severe anemic. So the hematologist prescribed me supplements to cover to fulfill to reduce my anemic symptoms because of my chronic kidney disease. So And perhaps as importantly, my family and peer support communities provide emotional strength every single day. I learn a lot from my community. So in Indonesia, we have young adults with chronic kidney condition, namely hidup ginjal muda. So since the stigma about kidney complications, it's in the society, and then you're a young person with diabetes and kidney complications. So it's a good community to empower you and to keep moving forward to pursue treatment. And every member of this team plays a unique role. Another important lesson is that diabetes complications are interconnected. Managing blood glucose is not only about preventing kidney disease, it also protects the heart, the eyes, and many other organs. Good communication between healthcare professionals is equally important. When specialists work together and include patients in shared decision making, care becomes more coordinated and effective. Patients should never be passive recipients of care. We should be active partners in every decision. And finally, we cannot overlook emotional well being. Living with chronic disease is mentally challenging, and emotional support is just as essential as medical treatment. The biggest takeaway from my journey is simple: coordinated care treats the whole person, not just one organ. Next, please. As we look to the future, I believe we all have a role in bridging the gap. First, we need earlier kidney screening for every person living with diabetes, so complications can be detected before symptoms appear. Second, we need better education and health literacy because informed patients make better decisions. Third, we need integrated multidisciplinary services where healthcare professionals collaborate seamlessly across specialists. And finally, we need equitable access to care. Every person living with diabetes, regardless of where they live, deserves the opportunity to protect their kidney health. Kidney disease may become part of our journey, but it should never define our future. With the right healthcare team, timely intervention, and empowered patients, we can preserve both kidney function and quality of life. And thank you for allowing me to share my story. Together, let us continue bridging the gap so that every person living with diabetes has the opportunity to live a healthier, longer, and more meaningful life. Thank you so much. Salih, back to you.
I think you're muted.
Okay, can you hear me now?
Yes.
Okay. Yeah, we just want to thank Anita for her beautiful presentation on bridging the gap on early kidney screening for every person. And we will be going on to the discussion on the panel discussions and the Q&A next. Okay.
I got a question about the DKD. Why is DKD an urgent concern? That is because it's a systemic disorder. Diabetic kidney disease affects a lot of other organs because DKD is associated with cardiovascular complications or other comorbidities as well. So it reduces quality of life, it affects the prognosis, lifespan, and it is a pain for the patients. We can do hemodialysis or PD if the kidney function declines, but that effect has a huge impact on the lifestyle. So we want to preserve their kidney function as long as possible. And unfortunately, before we had only RAS inhibitors to slow down the kidney function decline, but now we can stop, hopefully halt the progression of the kidney disease using these new reagents. So the view of DKD is changing dramatically. And I'd like to ask opinions by other speakers as well.
Okay.
Can I add?
Okay, go ahead.
I think because also about the lack of awareness about kidney complications, because I know the fear of having complications, and sometimes people rather of not knowing instead of knowing, so they hesitate to do screening. And I think it's important for us to educate our community about the importance of early screening and early detection, so we can have early treatment to slow down the progression of having chronic kidney disease.
Okay.
I think, Anita, you brought up a very good point about early screening because diabetic kidney disease, with early screening with something as simple as a renal function test or albuminuria, urine for albuminuria testing, quite a large majority of them can be detected early, and interventions, as what Prof Nangaku had mentioned, there are good kidney-directed interventions, and other measures that we could take to actually prevent progression. And the other thing that I would like to add, that kidney disease is also a marker of cardiovascular health. So often, I think we saw that beautiful images earlier on with regards to how it's intertwined. Patients who have kidney disease often also may experience heart disease that could be undiagnosed. So it's very important for us to detect it early and prevent progression.
Okay. The next question, what does the effective multidisciplinary care for diabetes-related kidney disease look like in your practice, and which healthcare professionals should be involved?
Yeah, so I think, Salih, that's a very good question. But honestly, I think there's the ideal or most effective way to deliver this care really will depend on your own individual region or country or place of practice, really. Because what that could be done in Malaysia, in my hospital, may not be what somebody else could be doing in Tokyo, in Japan, or in London. It really has to be, I think, tailor-made to your local setting, and also taken into account your own resources that you have within your reach in your country. And ideally, as what Anita had very beautifully, I think, pointed out, as a patient, it will be very important for it to be multidisciplinary, because patients are not individual organs. Because for me, like, I'm a specialist endocrinologist, so even for me, I tend to fall into the trap where I become very glucose focused, which I'm trying to step out and actually take a perspective and look at the patient as a whole, to have a bird's eye view on what's happening, and trying to look at him or her not only as organs, but also complex other interplays in terms of lifestyle, job expectations, family expectations, how the patient is coping. And I think really the delivery of care models really will require a team, as what Anita had beautifully, I showed you how it's done in clinical practice, and that's just one model where we are doing it virtually, where the multidisciplinary clinicians are actually sitting together to discuss a patient. But ultimately, I think, as what Anita had beautifully highlighted, is that the patient has to be part of that shared decision making as well, because without the patient's commitment or into that decision making, I think practice would be very very challenging. So I think it has to be multidisciplinary, it has to be patient centered or patient involved, It has to, of course, also to be locally sustainable. It has to be locally adaptive. What you can do in your setting, can it sustain? If you have, this large number of people living with diabetes, are you able to cater to all of them? Or are there individual regions in which you want to cater, or individual communities in your own setting? If you live in Australia, you might want to focus on certain communities which need more care. These are the kind of streamlining that has to be individualized to that local setting.
That's right. Professor Masaomi, your take on that question?
Thank you. I fully agree with Professor Jeya's view. And always primary care physicians play an important role from this aspect. And depending on what kind of complications they have, we need good collaboration, probably endocrinologists or cardiologists or nephrologists or whatsoever. And I think he made a very good point. Thank you.
Okay, thank you. The next question is for Ms. Anita. From the perspective of someone with lived experience, what is the greatest challenge people face when navigating care for diabetes and related kidney or cardiovascular complications?
Okay, probably the challenge is creating your team, because you need several specialists in that team. And most of the question is, who will be the leader of that team? I think it's really personalized based on the patient preference as well. But in my situation, I have my endocrinologist as my leader of my medical team, because I have diabetes longer than other complications. I have diabetes nearly 3 decades, while for my kidney and cardiomyopathy, it's last 10 years. So my endocrinologist, he's the person who reviewed all the feedbacks, all my medication. So I owe a lot of help from him. But it's a challenge for Indonesia itself. Why? Because as you see, we're a large country with 17,000 islands. So often, patients need to travel to other hospitals to visit another specialist, which means it's also will be less coordination as well. So it's more effort in terms of communication, coordination, and also decision making for the patients, because he or she, the patient, needs to travel across hospitals, meeting different specialists in different hospitals.
Yeah. In fact,
sorry, maybe can I add to that?
Sure.
Yes.
So I know Anita said the endocrinologist is her sort of leading her team of multidisciplinary care, right?
Okay.
But actually it's a bit different for us in Kuala Lumpur in Malaysia. Really, I think doctors are not the best leaders in most situations. It is you're laughing. It's the nurse navigator. So, my nurses are actually better, and they really form a good relationship because they are really the bridge. And my nurse navigators are the people who actually know the patients really well. They communicate at a personal level, because there are many things that patients sometimes don't share with their physicians, but they more easily share with their nurses, because nurses are more down to earth. And doctors also can communicate easily with nurses, and nurses are very good at keeping records, making sure everything is in order, making sure the doctors don't miss out a medication on the script, because doctors often do that in practice. I think it happens all over the world. So really, it's the nurse navigator. For me, it's a diabetes nurse educator, as well as some of my nurses who are into research as well, who are really leading the team, really making sure, they are, I think, the top on the tier with regards to, the multidisciplinary care model. So I would recommend that sort of model in some of you in other countries who are looking into adopting this, the nurse navigators.
Yeah, on both your points, it's very interesting, because in South Africa, if this can be adopted, it could actually work well, because of people being in the rural areas, and they can't get to their appointments. They've got traveling situations, or financial implications on traveling to their destination for healthcare. We've got another question for Professor Masaomi and yourself, Professor Jeya. This is a very important question that many people in our audience are bringing up now. How long is it usually takes for someone living with diabetes to develop CKD?
Thank you. This is an important and difficult question to answer because in case of type 2 diabetes, the disease develops silently without being recognized. So some people have already developed CKD when the diagnosis is made, while other people develop CKD after 5 or 10 years. And it depends on how good the blood sugar control is, how good blood pressure control is. In case of type 1 diabetes, I think it usually takes 10 or 15 years, but I'd like to hear the opinion by Professor Jeya.
Yes, I agree with you, Professor Nangaku, because in type 2 diabetes, actually, it's quite difficult to predict because we do know that there are individuals, some people who actually develop complications sooner than others. Some people are more progressive in terms of their kidney decline. Some people are more predisposed to cardiovascular complications. And there are people who sometimes, don't develop complications so soon. I think that should not be the focus. I think the focus should be more about, as what Prof Nangaku had mentioned, controlling glucose, controlling blood pressure, trying to reduce albuminuria, because now, for many years, we did not have medications that can reduce protein leakage in the urine. Now there are medications besides the renin-angiotensin or ACE or what we call ACE or ARBs. Now there are other drugs like the SGLT2 inhibitors and non-steroidal MRAs that can actually help reduce the progression, and that can really delay. And we know from the many different clinical trials which we saw earlier, and also in clinical practice, people can live longer without ending up with renal replacement therapy, or without needing dialysis or peritoneal dialysis or hemodialysis, by some of the interventions, the medications, the glucose control, the blood pressure control. I think that should be really our focus. And as mentioned earlier on in the discussion as well, detecting early kidney disease also, that has really shown to prevent progression, because when you detect it early, the chances of preventing it from progressing is much better than detecting it late. When you actually have not very high albuminuria, or your kidney function is better, you're in a bit more better stage of kidney disease, your chances of preserving kidney function with all the different interventions, the treatments, are actually much more successful. I think really we should focus on that.
Yeah. There's another question that is again for Professor Masaomi and yourself, Professor Jeya. Early kidney screening normally involve high out-of-pocket expenses on people living with diabetes in low, medium-income countries. What can be done to include such lab works in the routine screening programs besides laboratory analysis? How can kidney disease screening can be done?
Thank you. This is also a very tough question. The kidney is called as the silent organ because kidney disease develops slowly without obvious pain or warning signs. So people can lose a large number of their kidney function without noticing any symptoms. As this person pointed out, early screening requires some extent of money, but if you use dipsticks, it is much cheaper compared with the direct measurement of albuminuria. So I wish dipstick screening can be achievable in your countries, but I'd like to hear the opinions of Professor Jeya once again.
Yes, I totally agree. I think, Prof, I think the most cost-effective method will be a urine dipstick, which in most even low and middle-income regions, I think it's more easily accessible than actually sending it for an actual laboratory test. I think that itself, will be able to pick up some of the obvious proteinuria or albuminuria. And I think that's what we should advocate. And I think the more we use is when, policymakers or governments, or people who actually allocate funding, the more we use is when people will realize that there's an increased need. If we don't use it as healthcare providers or even as patients living with type 1 or type 2 diabetes, if we don't advocate the use of it, then, policymakers or governments are going to think it's not important. So we have to increase the use. The other thing is that there are places where I've seen people also doing point of care testing, even for creatinine. That is something that's also in there. It is available in some regions. It's not very expensive. It is something that can be done in especially in remote areas where they can actually point of care test for, using a finger prick, actually point of care test for creatinine. It's not extremely accurate, but it's good for picking up, overt kidney disease as well.
Okay, just a quick one from my side. I was diagnosed with obesity not diagnosed. I was actually told by a physician that I was leading to obesity. And how does obesity actually affect kidney disease? Professor Matsumi and Professor Jeya.
Thank you. Obesity has a burden on the kidney, and obesity is always associated with poor outcome of the kidney disease. Obesity induces hyperfiltration of the glomerulus, which reduces the kidney function. And there are some kinds of obesity-specific kidney disease, such as obesity-related glomerulopathy. In addition, obesity is usually associated with hypertension and diabetes, which is also a major component of the kidney disease. So at the clinic, I usually ask our patients to reduce body weight, although I know it is very difficult because I love to eat. And I'd like to hear the opinions by Professor Jeya.
Yes, I mean, I think, the science is there. There is obesity-related glomerulopathy. I think that's a known entity they've been published. There are scientific papers on it. And as what Prof Nangaku had mentioned, I think clearly, obesity is associated with other conditions that badly, negatively affect the kidney as well. Diabetes, hypertension, associated with dyslipidemia. So, and we do know that weight loss interventions do improve kidney function. So weight loss will definitely be beneficial. And I think some of the medications that they use for weight loss are also heavily being studied for kidney protection. Like the GLP-1 receptor agonist or the GLP and GIP and GLP-1 combinations, and the many different therapies for anti-obesity or obesity management are also, showing benefit in terms of heart kidney endpoints. So I think that's really promising.
Okay, thank you for that. There's another question again for Professor Matsumi and yourself, Professor Jeya. What is the most feasible and scalable approaches to improving early detection and preventing kidney complications in people with diabetes, particularly in low resources settings with limited access?
Thank you. This question is similar to the previous one. And once again, measurement of albuminuria is the proven most efficient way to detect early kidney disease. And early detection results in the preservation of the kidney function. But as I said, measurement of albuminuria is expensive. And in that case, urine dipstick is cheaper and probably more affordable. What I think we should do is to convince our government that these measurements will eventually turn out to be much cheaper than losing patients' kidney functions, because if they lose their kidney functions, the government lose their labors and their important lives. So we should convince our government that measurement of these parameters and early detection of the kidney disease deserves these finances. And I'd like to hear opinions of Professor Jeya.
Yeah, I think I agree. Prof Nagaku had actually mentioned, the early detection part of it, but I will stress on the prevention. Actually, the cheapest way to treating a disease is to prevent it from happening. And I think that is something, around the world, no matter where you live, I think we should all, whether you are, healthcare provider or not, I think we all have the responsibility of preventing some of these intertwined, as we have seen. Obesity, I think, is an important driver. Diabetes, hypertension, I think prevention of this condition is probably the most, best investment in preventing its complications.
Right. Okay. I've got a question for all our panelists. Okay, one of the attendees, Ravdi Sus, is the person that appears in the visual or this event. Okay. He has submitted a question and would like to know about the role of diet for people living with CKD. Anita, you want to start?
Okay, it's quite long actually for my part. So as a person with diabetes, of course, we have to calculate our carb intake. But when we're diagnosed with diabetes kidney disease, we also need to know about our protein intake, about the minerals, about the grams of the protein. And also one of the one important thing that my nephrologist remind is try raw food, not instant food. Raw food. Why? Because when you opt for instant food, there will be preservatives, coloring. I mean, all the chemicals, which is will be create a burden for your kidney. But when you go into the raw food, it's all natural. But still, you need to look closer to the minerals that they contain. And I have to admit, it's a hard shift when I was newly diagnosed because I usually eat protein, but when I was diagnosed with diabetic kidney disease, I have to limit my protein. So there's a moment where I have no idea what should I eat. But education is key, so never stop learning.
Okay, Professor Matsui, do you want to comment on that?
For the patients with kidney disease, dietary therapy has several different purposes. If patients suffer from hyperkalemia or hyperphosphatemia, they should reduce the intake of potassium or phosphate. Some other people do the dietary therapy to preserve their kidney function by low-protein diet. But this is very controversial because in the single-center study, low-protein diet can be effective, but in multi-center trials, there has been no studies which showed the effects of low-protein diet. And probably that is because low-protein diet is very difficult to stick to. And especially in aged societies like Japan, people with kidney disease are suffering from sarcopenia or frailty. And to these patients, we do not prescribe low-protein diet because we want them to eat more and to keep their muscle mass. So dietary therapy is very difficult, I think.
Okay, Professor Jeya.
Yeah, I think I mean, I echo everyone to say that I think it's quite complex in that sense. But I think the key for me would be that it has to be individualized to that patient because, again, from different regions, different cultures, different food practices, different access to different types of food and people's, it's variable, based on your affordability of food and your access to food around the world, around the region might be different. So we really although we know what, we can give a sort of blanket instruction, but I think actually getting into the details or the nuances, it has to be tailored to, you have to understand your patient's meal plan, lifestyle, access to the food, how much he or she can actually afford. I think that's where, and we have to tailor make it to his or her own lifestyle. I think I just want to add that.
Okay. Okay, we've got a lived experience type of question, and this is for Anita. And the person actually asked, how do people living with CKD feel in different parts of the world? Okay, what have other people told you in relation to their lived experience, Anita?
I think the hardest part is the stigma itself, the stigma of having complications. Because as a person with diabetes, and then when you develop complications, people think that you fail on managing your diabetes. That's why you develop complications. That's one. And the second part is about how to manage expectation of people around you, because people think that complications is the end of the world. Often in some areas in my country, when they were diagnosed with complications, they stopped pursuing treatment because they thought it's the end of their life. So how to shift the mindset that through early detection or early treatment, you can slow the progression and you can still live your life.
Yeah.
But I know it's related with access. So it's the theme of today is bridging the gap. So let's bridge the gap together.
Yeah. In fact, in South Africa, it's exactly the same, where the education is also an important part on bridging the gap, because of limited resources that we actually have here in the, we can say, in the public sector, and people go undiagnosed or misdiagnosed in many parts of the lower and medium income countries. Okay, there is a. Do you want to have a final say, Anita, on that?
Yeah, that's why. I mean, it's. I know it's difficult, but it's a life experience. I will always encourage people to keep moving forward. Why? Because I've been there. I mean, I was diagnosed with chronic disease stage 2. My hemoglobin reached 6,000 when I was diagnosed, and now it's 200-ish. Thank you to the medication and the treatment that I get. But again, don't give up. Pursue your treatment.
Yeah. Never give up.
Yes.
Okay. We've got questions. What time are we ending? Is there any more questions or related to the topics that we're actually speaking here from people? Okay, we will just check on that. Okay. The next question. How many multidisciplinary teams better address the physiology and social and everyday realities of living with both diabetes and kidney disease to improve community of continuity of care and outcomes? That's for all of you. So whoever wants to go first?
I can.
Okay.
Can I?
Yeah.
Yeah. As I mentioned earlier, that I live with several health conditions. So I have type 1 diabetes, cardiomyopathy, cardiac disease, thalassemia, asthma, celiac, and also rheumatoid arthritis. And some of the medications, they contradict, such as my corticosteroid medication for my asthma will raise my blood sugar, or by limiting my protein intake will put me into severely anemic since I have thalassemia. So that's the important role of my medical team, where they provided me reviews and feedbacks and asked me there's a one incident that made me realize that my medical team is working hard for me is when I have an asthma attack and the other doctors told my pulmonary specialist that this corticosteroid will raise my blood sugar. And do you know what my pulmonary specialist said? Anita cannot breathe. You need to breathe. And at that point, I realized that this medical team provided me structure. What's the importance of my life? And that's why I'm completely grateful for them, because they're working a lot. I mean, with all the decisions that they made for me.
Okay. Professor Matsumi, your take on that question?
Thank you. This is a very important question as well. And to have a good communication, we need a conductor. So it depends on which disease aspect is the most important at that point of time for that patient. If the blood glucose control is very bad, probably endocrinologist can be a conductor. If kidney dysfunction is a major problem, probably a nephrologist can be a conductor. And nurses also play a very important role, because they hear the voices of the patients usually much more often than doctors do. And patients usually make complaints more often to nurses than they do to doctors, at least in our country. So nurses can make a good connection between these multidisciplinary teams, I think.
Okay. Professor Jeya?
Yes, I mean, I echo everyone else to say that, yeah, I think the nurses are important navigators. That's the model that we are implementing in Malaysia, a nurse-led care rather than a physician-led care, where where nurses can form a good bridge to get, for the gap between physician as well as patient. And I think the other question was about, how do we address some of the psychological impact of disease on patient. I think in many centers around the world, there are liaison psychiatrists or psychologists that can get involved, psychologists who are specialized in non-communicable diseases or diabetes and obesity or even CKD, where they can be incorporated. So the team can expand. If you do have a certain case which require a more detailed psychological as sort of evaluation and management, I think then a psychologist can be brought into the picture. And that's sort of what we are trying to practice in Kuala Lumpur in Malaysia, where, for certain cases, when we are doing certain cases or discussing certain patients, we do incorporate some exercise physicians, for instance, or in some situations where they could help with the patient's weight loss, or a psychologist if we think, food-related cravings are a big issue, whether any intervention can be done there. So I think really involving some of the specialized persons or experts in that field will be useful. And overall, I would still think a nurse-led care will be ideal in most of our settings around the world.
Thank you for that. I just want to mention that we are having an influx of questions from the attendees, and unfortunately we will not be able to have time to actually respond to all of the questions to the attendees, because we are actually running out of time, and we would like to actually move on in in the allocated time for this program. Okay. Our next question, in fact, it was actually the same with the integrated nurses and in the teams. Just from my take, being diagnosed and as a lived experience like Anita, it is also concerning from my side, where we don't have that multidisciplinary type of care that we actually need in lower to medium income countries. From our perspective, from lower medium income countries, how would we actually go on to take better care of ourselves besides the dietary and the medication, just on a general take from all of you? How would a ordinary person like myself, if I say, how would we go about taking care of our bodies? Professor Masaomi?
Thank you. That's a difficult question, and as Professor Jeya pointed out before, individualized approach is very important. And my recent concern is the utilization of artificial intelligence by patients. In my clinic, one patient who is very intelligent, he's a Japanese, but he studied in US. He's the top engineer. He utilized artificial intelligence and got the advice of dietary therapy. And after 1 month, his kidney function declined dramatically because of the wrong advice by AI. And I think in many countries, patients start to use AI more often, but they should be very careful because AI gives only the, what should I say, average. They does not take all your conditions into account, while doctors and nurses do. So I want to our patients to be very careful about utilization of artificial intelligence to take care of their bodies.
Yeah. No, thanks for that, Professor Masaomi. Professor Jeya?
Yeah, so Salih, I think you brought up a good point about, sometimes if you are in a lower or middle income region, you might find it hard to access some of the specialized ideal care, right, which has so many specialists. But the truth is, most of these care models, although, it may not be state of the art, but can be delivered by your own local primary care physicians to some extent as well. And even by your local, in some places in the world or remote places, there might be only nurses who are actually, managing or medical assistants, whatever you call some of these people who are actually managing, they might be allied health professionals, they are not doctors, nurses, or even medical assistants who might be managing. And in most situations, for most people, they can really form a very important impact in the sense that, they can do early detection and screening. They can actually, educate patients and communities because they are closer to the community, right? So they can actually educate patients. And in these areas, sometimes, which could be so remote, you could have, if just say if you have only a certain number of specialists, you only have 10 endocrinologists in one country, and these endocrinologists sometimes can visit these places periodically, maybe once in 6 months or once a year, or even do some sort of virtual consult. And another way to actually look into it is actually to triage or to risk stratify the patients, where patients who actually need the care, if you can't give the access of multidisciplinary care to everyone, I think it will be important to give it to people who need it the most, because people who are at highest risk. You might think there's some disparity there, but again, that is because people who have the highest risk probably will progress faster and they will need more urgent care. So you're actually trying to triage or trying to risk stratify them and treat them a little bit more aggressively if you have limited access to care. And I think generally family physicians, nurses in your community, or any allied health professional, it could even be a local community dietitian or community nurse, or allied medical assistant who can actually sort of, gather the community. He or she would know the community even better and can really bring that care. It doesn't have to be 100% specialized state-of-the-art care, but I think a lot of this basic education, information, screening, and basic care can be done and does not need to be done by a very highly qualified physician.
Thanks for that. Anita, your take on this?
I agree because especially when you're coming from rural areas, I just visit Gorontalo. It's a coastal province in Indonesia, and there's a very small number of specialists in that island. But I know that they optimize what's available in that island. We have community healthcare workers, we have the community, we have the nurses, we have the dietitians, and we make the best of them as a team, so they can coordinate and even communicate with other specialists from other islands for the sake of the healthiness of the patient. So I think there's always a way.
Okay.
There's a way.
Okay. I've got a question for all our panelists. Okay, how can technology support people living with diabetes and complications, especially in theory?
Thank you. Can I start?
Yeah, can go ahead.
Technology is a very powerful way to treat diabetes. For example, there is the technology which is called the artificial pancreas system. This is the loop in which the machine monitors blood glucose and changes the ratio of the insulin administration. So this pump automatically adjusts insulin administration by monitoring blood glucose by itself. In addition, there are new technologies of telemedicine these days, and there are many smartphone-based applications. Last year, there is a paper published in JAMA which showed the success of phase 3 clinical trial, which showed that the intervention of lifestyles by remote AI-based diabetes prevention program was non-inferior to human-led diabetes prevention program. So these types of telemedicine or smartphone-based applications can also be a big success in technology as well. And I want to hear the opinions by Professor Jeya.
Okay. Professor Jeya?
Yes, I mean, definitely I echo that. I mean, the technology has brought great change to the management of diabetes and its complications. I think really, at least, I mean, definitely in the last 10 to 15 years, we have had a lot of that. I think Anita also was showing us her insulin pump just now on screen. And I think that's really made revolutionize. I think if you're on a insulin delivery device, I think definitely that is, with monitoring systems that revolutionize, especially type 1 management, but even in type 2, I mean, increasing use of continuous glucose monitoring and telemedicine has enabled, us to reach many of it, like we mentioned about, some of the physician consults that could happen virtually. In many of the remote areas in many of our countries where, patients can't get easy access, they need to travel hundreds of kilometers away. I think definitely technology has made a huge impact in the advancement. But I think two things important. Prof Nangaku mentioned about the correct use of technology. It could be misused or abused or used wrongly. And the second thing is technology is only useful if it actually has, you can access it. So if you're in a place where you don't have access to technology, then again, it's something that, just you see on the screen or on an advertisement somewhere. It's important for us to get access. So like for type 1 diabetes, I think especially if you're looking at insulin pumps around the world, I mean, we have to advocate the use of these closed loop systems. Only then, I think, again, policymakers and the different bodies who can actually fund these for our patients will actually even consider it. If it's such a low uptake and we find it, if we don't advocate the use of it as healthcare providers or patients, if we don't voice it out, become our own advocates for health, definitely the policymakers are not going to pay attention to the need of these technology devices, getting to the right people.
No, thanks, Professor Jeya. Anita?
Yes, it's interesting because I'm using CGM after I was diagnosed with kidney complications, because I know that I need to be more tight on my blood sugar range. That's motivates me to use technology. Beside the pumps and the CGMs for better diabetes management, also technology also provides you information about food that you will consume, because it's really funny because as Indonesians, I eat a lot of vegetables, but I eat quite a lot. So until one day my nephrologist said, Anita, don't eat too much. It contains purin. Oh, okay. or like such as like tempeh or tofu. It's just basic food for Indonesians, but apparently it contains phosphor, which is not good for the kidney. So I mean,
That's right.
the changes of eating habit that we used to have culturally, locally, and then we have to a bit shift, a bit limiting the intake, which is quite a challenge for a while. But you learn, and then I think that's the benefit of technology, because you can have a lot of information coming about the food that we'll consume, and I mean a lot of things, including information, including in community as well. Because I know community plays a lot of roles for our support system. Because honestly, when I was diagnosed, I don't know where to go. Because it was in my 30-ish, and I have diabetes, kidney complications. Where should I go? Because if I went to the hospital, most of them are older people. Well, I'm still young. So the community plays an important role, because I can meet young people with diabetes, kidney complications, and I know that they're surviving well. Some have kidney transplants, some have dialysis for more than 10 years, and they're doing wonderful. So I have a lot of encouragement coming from the community as well through technology.
Okay. No, thanks for that. Okay, we have one last question, and that will be, how can we find out more about... Okay, sorry. Let me rather do this last one here. It is, how about the multidisciplinary team? Is there a role for a family physician in these teams? Okay, Professor Matsui.
Yes, thank you. I think the role of family physician is very important here. The primary care physicians are likely to be the first and most frequent point of contact for the patients, and therefore they play a pivotal role in early diagnosis, establishment of effective treatment strategies, and coordination of care by specialists such as endocrinologists, nephrologists, or cardiologists. So their roles are very important, I think.
Yes, so I'll add to that, Salih, to say that yes, definitely. I mean, for us, for our own CareMe model that we are actually practicing in Malaysia, currently it's running in a tertiary care hospital, which is the hospital where I work at, and we are looking at actually, incorporating our own primary care physicians, because we do have a couple of clinics around the Klang Valley. Who actually communicate with us in terms of referring patients, and we refer them back to some of these primary care providers. And we are trying in the next phase, trying to incorporate family physicians or primary care physicians as part of the model. So, the hospital-wide multidisciplinary clinics will incorporate primary care physicians. And so that, most of the care is actually sort of decanted or really mainly in the hands of the primary care physicians, and little bit with the guidance of specialists in tertiary care hospitals. I think that is an ideal model. We haven't managed to practice that completely yet. And I think there's also some questions about how to find out more about the iCaReMe. So there are many different centers across the world which have joined the CareMe Global Alliance, and in Malaysia, University of Malaya, where I work at, is one of that. And you can find out further. You can also email me if you want to know and get connected to the CareMe Global Steering Committee or Global Network. And you can be part of that registry, because the data is also being collected. If you agree, data from your countries can also be collected. And we are in the process of writing up the initial paper, which talks to which is going to reveal to us the CareMe model, as well as the baseline demographics of these patients who are in the CareMe model.
Okay, thank you. So Professor Jeya, so you answered that question on how to find the CareMe, and I think we're going to be coming to the end of the program, and before that there is a couple of slides that we will be going through, and so I want to thank the panelists for their contribution and the insights to everything. We really appreciate it. Okay, thank you for the discussion. And my closing remarks and on everything that I've actually taken away from the lived experience and from Professor Masaomi and Professor Jeya and Anita, our lived experience. We just want to actually thank everybody for coming on board, who made this program especially successful, and the amount of people that came on board. I want to also actually just iterate that as a lived experience that has gone through kidney failure at the beginning of my life at the age of 12, and understanding obesity and going through the complications of diabetes. My journey wasn't easy, but there is a takeaway of don't give up and taking care about yourselves. So yeah, we just want to thank everybody for coming on board, and Professor Masaomi, Professor Jeya, Anita, for your contribution to this successful program. We want to thank everybody. Thank you. Oh yes, our IDF Congress 2027 to take place in Singapore on from the 10th to the 12th of April 2027. Especially the essential platforms for scientific exchange, professional collaboration, and advocacy. Registration will be open in July. Abstracts submissions close on August the 15th. And the IDF2027.org, that is the connection. Thank you. Okay, sorry, here's another announcement. The recording slides and feedback questionnaires will be sent to all registered in a few days. Please respond to the feedback questionnaire to help us to improve future IDF online events. Send any questions you may have to advocacy@idf.org. Thank you.